like this. Thank you, Francois, for your trust and your invitation. I will talk to you about my technique of treatment in brain injured patient for non-functional hand. I have the technique and the retrospective study. The question is which procedure to offer to this kind of hand. My goals are I want to lengthen the diagonist of the deformation, fix definitively the wrist and fingers in a neutral position, and prevent intrinsic secondary deformities. I only talk about non-functional hand in this series. I have 28 patients between 18 and 84. The majority were strokes, and every patient had at least 2 years of follow-up. All were grade 0 in house classification. 24 patients had had a toxin botulinum injection before surgery, and no patient had any surgery for wrist or hand in this area. I use the goal attainment scaling with level 0 for expected outcome, and the 2 levels more when it's better, and -1 and -2 when it's worse. To help the patient to choose a scale for the result, we propose the hygienic goal, aesthetic goal, or pain goal. And most of the patients choose an hygienic goal. The gas was made at 6 months. And I measure the angle between the age of the second metacarpal with the radius at 3 months, and for all my patients at 2 years, to see the position of the wrist after using this material. So I call the surgical pressure the hand fricate. I made skin incision on the left palmar one, on the right the dorsal one. By the forearm approach, I make a complete section of every flexor tendon for the wrist and for the fingers. This is the first time. After I do a dorsal tenodesis of the wrist, for doing that, I use a fiber tape from Artrex Laboratory. I begin with an exposure of the basis of the third metacarpal. I wrap the tape around the basis, and after I make only a simple note. I pass in a tunnel my tape from the distal part to the proximal, like this. I use a metal, and after I'm doing a drill in the radius. I make a drill in the radius from dorsal to anterior, and by this drill, I pass my tape from posterior to anterior, using like this. And since this first position, I'm able to fix the wrist in the position I want. I make this. The first time, I'm going back to the third metacarpal, and I'm doing this twice. I make 2 complete buckles. It means I use 4 layers of my tape, like this. And I do the proximal fixation in the same approach, in the same dorsal approach, with an ankle. So the procedure, I'm beginning with a complete tenotomy of the flexor at the forearm. After I make the wrist tenodesis, and if I have intrinsic retraction, I only do a percutaneous tenotomy of the intrinsic. If it's not, I do a partial neurotomy, except when it's in articular stiffness. And at the end, I do a tenodesis of the flexor at the flexor of the retinaculum. I use a palmar approach in the hand, By this way, I can do the neurotomy, the partial neurotomy. And I'm fixing the flexor at the retinaculum with a note. It's something very strong. And by this way, I can adjust exactly the position of every finger if I want to have them more or less flexed. I just make a note and fix it like this. At the end, you have a mobility like this with a good elasticity of the finger and a very good position with a good aesthetic outcome. The result of my study, at 6 months, we have a majority of positive gas with a mean gas at 0.43. The angle is quite stable between 3 months and 2 years. We don't lose any angle of fixation. The complication were in 3 cases hypertonic and thoracic deformities, 2 after tenotomies, 1 after neurotomy, 1 claw end with a patient with hypertony of his extensor, and 1 infection on material. We need an ablation of the material. 1 rupture. Maybe it was an improper rehabilitation because the physiotherapist, I don't know exactly what happened, but I'm afraid that every day he tried to flex it, to see how he can do it. In conclusion, it seems stable and sustainable fixation of the wrist with reduced incision, an aesthetical outcome. Using the fiber tape give us more resistance than only using the tendon. It's easier to do than an arthrodesis. May we do a systematic prevention of intrinsic deformation? I think so. I think it's useful to do it. For the complex flexor tenotomy, of course, there are no space for motor recovery, but doing this flexor tenodesis give us an excellent aesthetic outcome. For tomorrow, I have to increase the follow-up duration and the number of patients, and maybe extend the tenodesis to functional hand, maybe partial functional hand, but it may be useful for that. Thank you, and thanks to Arthrex for his help.
Thank you very much. There's some question in the assistance. Philippe Normandie.
Merci beaucoup, Alain. 2 choses. D'abord, je trouve ça très intéressant, ta proposition dorsale de ténodèse. À la place du tendon, je pense qu'effectivement, ça se compare et ça peut nous régler beaucoup de situations. Finalement, il y a pratiquement plus de place aux arthrodèses, ou en tout cas, on pourrait les discuter. Sur la partie antérieure, moi, je suis très gêné de ta proposition de couper complètement. Pourquoi? Parce que on a trop vécu des patients, on est sûr, crachés par terre, qu'il n'y a pas de commande, et en fait, il y a un tout petit quelque chose. Et deuxièmement, je trouve que tu as une population jeune. Qu'est-ce que sera la médecine dans 10 ans ou dans 15 ans? C'est-à-dire, quelles seront les possibilités de stimulation dans d'autres systèmes? Donc, je trouve que le plan antérieur, elle est 90 ans, 95 ans, je ne me pose pas la question. Et je ferai encore plus ça, je ferai une ténotomie simple. Mais, ou ta proposition. Mais en dessous, moi j'ai une vraie interrogation. Et est-ce que finalement, les allongeants d'une incision un peu plus longue, mais quand tu fais ces ténotomies, entre guillemets, en Z, sans suture, tu lâches, tu gardes une cohérence et une continuité. Moi, je trouve que dans nos approches en neuro-orthopédie, ce qui me gêne, enfin en tout cas dans mon évolution, c'est de me dire comment je ne me coupe pas les ponts pour demain. Et je ne sais pas ce qu'est demain. Et c'est là où ça m'interroge.
Philippe say that the first part is interesting with this technique of stabilization of the wrist, and for the second part, what I do with my complete tenotomy of the flexor. Of course, that's I said to you that we have no future of recuperation of this flexion. And maybe we have to let them, at least in continuity, to be sure that it can change. I choose for my patient really or stroke or adult with many years without any function, and that's why I made that. But surely we can say that we have to change the second part, or in some case, to let continuity in the flexor.
Thank you, Alain, for this very interesting presentation. I have one question, and mainly about recurrence of the flexion of the wrist. Don't you think it would be interesting to assess the pronation of the upper limb? Because with the gravity, when we see some recurrence, it's mainly when you don't perform arthrodesis, but when you're doing with tendon and maybe with your graft, I don't know, that it would be after 1 year or 2 year recurrence because of the gravity, because they are in a pronation situation. And don't you think that it would be interesting maybe to neutralize, the pronation? Because every time we see, recurrence of the flexion of the wrist for this non-functional hand, it's because they are always like this. And with time, the hand is going down like this, and there is a recurrence. Because your follow-up is about 6 months. It's
2 years.
2 years. Yes, it's quite long. But I'm not sure with your technique. I think you have to maybe to check if the population with pronation is not going to.
But I didn't talk about, but I did it in some patient. I do a tenotomy as well of the pronator. But the idea was to hope that this material won't change in any position of the wrist. Mais c'est sûr que oui, il faut s'intéresser aussi aux positions de pronation pour le patient aussi. Quand on parle de résultats esthétiques, bien évidemment, c'est mieux quand ils ne sont pas complètement en pronation malgré la récupération. C'est vrai aussi pour les déviations latérales.
Oui.
Is it necessary sometimes in severe flexion contracture to combine first row carpectomy to diminish the tension?
No. And
In
you have enough strength with this tape really to put your wrist in a position not completely extend, but to go as 30 degrees in each patient was easy.
Oui, une question complémentaire. Dans la paralysie cérébrale, on a souvent une fonction de la main et au fil des années, un poignet qui est de plus en plus en flexion. On serait intéressé pour essayer de limiter l'hyperflexion des poignets tout en le gardant en flexion, ce qui permet l'ouverture de la main. Est-ce que votre système de ténodèse avec vos fibres permettrait de garder par exemple un poignet à 45 degrés de flexion pour limiter son évolution vers les 90 ou 100 degrés de flexion qu'on voit arriver avec les années?
A priori, on peut le régler dans la position qu'on veut.
Ça ne va pas capoter sur le côté, le système. Parce que vous le mettez sur le 3e méta, c'est ça?
Oui, je le mets dans l'axe.
Parce qu'ils sont souvent en flexion ulnaire.
Oui, ça ne règle pas complètement les problèmes de déviation. Il faut quand même réaliser des ténotomies et essayer de les rééquilibrer.
Ah oui,
Il n'y a pas dans la bandelette quelque chose qui va limiter les déviations latérales.
Ouais.
Et la question, effectivement, c'est de dire...
Oui.
Oui, bien sûr.
90% font une luxation antérieure de l'extenseur ulnaire du carpe. Et donc la question c'est, est-ce que c'est pas ce tendon qu'on pourrait utiliser? Faut-il renforcer ou pas avec une ténodèse? Mais je pense que le sujet clé, c'est quand même la position de l'extenseur ulnaire du carpe qui est devenu fléchisseur et qui pollue le système. Dans cette population.
Juste, excusez-moi, dans la série, je vous ai parlé que donc, du positionnement des doigts et du poignet. Il faut effectivement de temps en temps associer d'autres ténotomies. Et systématiquement, quand il y a une luxation antérieure de l'extenseur ulnaire du carpe, je fais une ténotomie de l'extenseur ulnaire du carpe parce que c'est qui va nous laisser une déviation ulnaire qui n'est pas traitée par cette technique, quel que soit le positionnement du poignet.
So many thanks, Alain. It was as a rehabilitation doctor, I would conclude whatever the technique is, because it's your cooking strategy. As a rehabilitation doctor, I'm happy to learn this because we need to operate those patients with an incomplete result with toxin for a long time. So don't be afraid about those kind of surgery. Of course, you know this, but thank you. It's a frequent problem and it's very good, provide good results. Our next speaker.